Thank you, everyone. I'd like to welcome Taria, who will be talking more about the wonderful work that's been happening in the Manatū program and providing us with some more of the detail. Thank you.
Kia ora koutou. Ko maunganui te maunga, ko waipoa te awa, ko te roroa te iwi, ko Taria aho. That was a hard act to follow, Rawari. But essentially what I'm going to be doing is talking a bit more about the Manatū program and I guess touching on the more operational and practical details. Just to provide a bit more sort of context to the question earlier, the clinical outcome data is currently being analysed by our statisticians, so the figures that are up there are a little bit outdated. We are hoping for more promising results, and actually our aim was to get a between groups difference of 6 millimole to be clinically significant. So we're not far off that, and we're hoping that that figure will change. Ko waio, just introduced myself. So I should say I was the network manager on the Manatū diabetes program. My role wrapped up late last year, so I haven't been sort of in touch with Manatū for a few months now. But when Mātere said she couldn't make it today, I sort of jumped at the opportunity because I'm really passionate about this mahi, and I think it is hopefully the future for the New Zealand health system. So I was hoping to sort of have a bit of an interactive session today, and firstly just wanted to ask, are there any sort of areas of interest for people, anything in particular that they would like to know? Just raise your hand and or shout out at me, otherwise I'll just kick on and we can do a Q&A or something at the end. No? Cool. So hopefully I cover all the bases. So just as a rough agenda, I'm going to be talking about the sort of zoomed out high-level features of Manatū, and then I plan to sort of zoom in and look into a bit more detail about what the program sort of, how it works operationally. I'll then talk about what happens at the Manatū home visits, which is a really key component of the program, and then talk about what happens outside of those visits. Then I sort of want to pose a question of sort of how do we add value to our approach and our model to the crowd, and then talk about sort of next steps for us and a Q&A. But yeah, please feel free to sort of interrupt me, just raise your hand if you've got a burning question. Happy to stop. So I guess to kick off, I wanted to sort of pose a case study. So John is a 63-year-old male with an HbA1c of 102. And John heads into his GP clinic to get a prescription for his high sugar meds. Can anyone sort of tell me what might happen during that consult? What's the typical sort of formalities that go on during those sort of consultations? Feel free to yell out. I'm sure we've got some doctors and nurses in the room. Yep, blood test, yep. Anything else? Yep. Health education, yep. Yeah, medications, yeah. Sorry, what was that? Yep. So yeah, all of those things, yep. Oh, sorry, I missed that. Do I have a hearing impairment? Okay, yeah. Yeah. Those are all sort of, all areas that will, I guess, get touched on during the consultation. But I guess the key point that I'm trying to make is that that consultation lasts 15 minutes, and if they're lucky, they'll get 30 minutes with a nurse, typically afterwards. But what's going on behind the scenes for John? So John and his wife live in a 2-bedroom property with 5 other whānau members. John's wife has been ill recently, so he's been caring for her full-time and cannot work. They're struggling to pay the bills. John rarely attends his health-related appointments because of their financial situation. He feels that his doctor growls him when he goes to see his doctor, and he is whakama about his poor health. More importantly, is John has been living with type 2 diabetes for about 2 years, but doesn't actually know that he has type 2 diabetes or even what diabetes is. So all of these sort of points I've listed here are sort of stories, come from stories that from participants in the program that they've told me sort of face to face. That last one was particularly sort of shocking. But yeah, essentially, there's not enough time in those GP consultations or consultations at the clinic to touch all of these bases. So I guess our answer is that through Manatū, which is a Māori-led pro-equity approach to supporting whānau living with long-term conditions, we might be able to dig deeper and sort of work on those things that are happening behind the scenes. And I guess when we talk about pro-equity, we're acknowledging that there are significant inequities that exist in our healthcare system that have been sort of brought on by the various flow-on effects of colonisation and breaches to the Treaty of Waitangi. So Manatū sort of stops seeing people as a problem and instead sees policy and systems, structures as the real issue. So what are the features of Manatū? So firstly, we have Māori leadership and a Māori and Pacifica workforce. Manatū was co-designed with whānau clinicians and service providers, so at the start and throughout. We did continuous quality improvement throughout the program. Manatū is mana enhancing and whānau centred. It's equity driven and tackles the wider social determinants of health. And a particular feature is our fabulous Kaimanaaki role, which we think is a potential solution to a lot of the disparities in the healthcare system. So what we believe that leads to is that whānau living with a long-term condition are better supported to Manatū or stand with authority. But if we take a sort of closer look, we zoom into those features. What I mean by Māori leadership and Māori and Pacifica workforce is that it's led by a really prominent Māori researcher, Dr. Mātere Howard, and it's led by a Māori-led PHO, the National Hauora Coalition. The hub, which is basically me, I was the hub, was a pretty core component in the program, and having that ability to work and be embedded in a Māori-led organisation to operationally support the Kaimanaaki and our provider network was a key strength to implementing the program. And lastly, our Kaimanaaki. So we had a dedicated team of Kaimanaaki, and they delivered the Manatū program. And I'll touch base on the Kaimanaaki role a bit later. But why is it important to have Māori leadership and Māori Pacifica workforce? It's because people need to feel that they are culturally safe. It's really important to the whānau that we work with. So I've just popped up a couple of quotes there. These quotes came from a qualitative sort of sub-study that we did, where we interviewed around 30 Manatū participants and their whānau, just to get their story and their journey. So the first one says, what was from a Manatū participant talking about his GP clinic and ways that he thought the system could be improved. So he said they want to speak with someone who speaks their language. They're talking about patients here, for starters, who knows their culture. And I think if they want to start getting a bit more targeted at their treatment of diabetes, that's what they need to look at. So when we're talking about cultural safety, some aspects are more tangible, so things like being able to speak the language of the patient. Then I actually went out and interviewed these participants. I sat with a beautiful old kuia, and she said, I respond a lot more to Māori because they know how Māori people, especially old Māori people, and the ways that we sit, which is kind of a more intangible, deeper meaning of being culturally safe, I guess, and encompasses the cultural worldviews, cultural contexts, all sorts. So I just thought that was really powerful. So Manatū was co-designed with whānau clinicians and service providers, and we really tried to privilege the whānau voice and experience throughout the program. We had an ongoing collaboration with clinicians and our service providers. I worked one-on-one with them. We had various hui. Our Kaimanaaki often provided feedback through the clinicians, and the clinics that they were embedded in. The program is mana enhancing and whānau centred, so we are advocates for whānau. We have a rights-based approach, which I already touched on earlier. We work with the manatū client and their whānau, so we openly welcome whānau members to come in and sit in on visits with the Kaimanaaki if the manatū participant wishes. But more importantly, we're walking alongside the patient and their whānau and their journey to live well. And then just up the top there, I've just put in another quote from the qualitative study. And a manatū participant said, "I think it was perfect timing because when the Kaimanaaki came on, my auntie was staying with me during that time. And I think it was the way in which the Kaimanaaki approached it. Instead of excluding my auntie, she actually included her. So that and my auntie found it really beneficial for herself. So that has had a rippling effect for her as well." So manatū is equity-driven, tackling the wider social determinants of health. So it's not just ABC. And I actually had this comment come to me from one of our Kaimanaaki, who I think it might have been the second week in the role. And she said, it's not just ABC, it's not a 3-step and you're fixed, problem solved. It's more like A, B, C, D, E, F, G, H, I, J, K, da, 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 da. And basically what she was saying is that people that we work with, they're living in such high levels of social stress and they have really complex needs. So it takes time to break through those barriers, I guess. Another important function of the program was social goal setting, which really improved whānau connection and reduced a lot of social isolation, which was quite interesting. So lastly, the Kaimanaaki role. And we do see it as a potential solution. And I've just popped another little quote up there because I think it's really cool. And this quote said, this was from a whānau member of a manatū participant, and the Kaimanaaki would go and do things for him at social welfare, and that was a lot lifted off his shoulders, He didn't have to go. The Kaimanaaki did it for him, and it was so helpful. We couldn't believe it when she went to social welfare, and she'd come back straight away, and we'd be like, how did she do it so fast? If I was to go there, I'd be sitting in the queue and waiting for hours and hours, which is what I have experienced. So the Kaimanaaki role. It's kind of hard to explain what it is. I think it encompasses aspects of health coaching, aspects of navigation and community work, but it also has some additional sort of features, I guess, where they are providing sort of basic DSME and health literacy education. They have an extended reach, so they are working with the patient and the wider whānau. They are integrated and embedded into the clinics, which was a really key part of our program and how we implemented the project, I guess. It took some time for GP clinics to sort of come around to the idea of having a Kaimanaaki in their clinic. They weren't used to this sort of social role, but by the end of the program, they saw the role as a key component to their clinic and the way that they do things. So what can manatū visits look like? So in a nutshell, the Kaimanaaki go out and they'll visit their whānau, we'll say a minimum of 13 times over the course of 12 months. Typically, to start off with, the visits are intensive, so they'll go on a weekly basis, spend about 1 to 2 hours with the patient and their whānau, and then those visits start to drop down to sort of fortnightly or monthly, depending on, I guess, how complex the case is. But during those visits, at the start of them, always whanaungatanga. And I know feedback from the Kaimanaaki is that it takes at least sort of 2, maybe 3 visits just to start building that trust and relationship with the patient and their whānau. Typically, they'll start the visit off, if the patient wishes, with a karakia. They'll set an agenda for the visit. They'll check in with their health and social needs. They'll do some basic diabetes self-management education. Then they'll go on to health and social goal setting. And then following on from that, they'll start coordinating any care that's needed. Cool. So what happens outside of those visits? Let's say the Kaimanaaki goes back to the clinic and they immediately start coordinating care. So any sort of follow-up on WINS appointments, Housing New Zealand appointments, if the patient indicated that they maybe wanted to take a cooking class, the Kaimanaaki would help facilitate that. We had one Kaimanaaki doing some coordination around immigration because a whānau had some immigration problems that they just didn't know how to navigate that space. So the Kaimanaaki facilitated that. They also report back to the GP clinic, so updating in the PMS any notes from the visit, the debriefing their clinic champion, which was typically a sort of lead practice nurse or GP that sat within the clinic, scheduling follow-up appointments. They would do regular peer support hui with the rest of the Kaimanaaki team and myself, and during those hui we would take some time to sort of critically reflect on, I guess, some of the things that the Kaimanaaki may have been dealing with their whānau, so we'd sort of all come together and share our learnings. And a really powerful, I guess, strength of doing those hui was we have a health psychologist at the NHC, and she would come along and just help us make sense of some of the really complex stuff that was going on for some of the whānau that we were working with. Kaimanaaki were contributing to continuous quality improvement activities, and there were a lot. And we also did as much as we can to get our Kaimanaaki further upskilled, so lots of training and development opportunities. So back to John. So I've kind of just sort of put up a scenario if John was to be enrolled on the Manatū program. So let's say the GP is concerned about John's high HbA1c and refers him to a consultation with their clinic's Kaimanaaki. So John agrees and meets with his Kaimanaaki on a weekly basis to start. And by visit 3, John's Kaimanaaki learns that John hasn't been taking, taking his medications because of dodgy side effects. And he doesn't like taking them. So John's Kaimanaaki recommends to see his GP and offers to come along to the visit as support. John accepts and gets his medications changed, and then John starts taking his medications again. So John's Kaimanaaki slowly introduces diabetes self-management education, and John starts to learn about his condition more. John's Kaimanaaki then supports him to secure vital WINS entitlements to help ease his financial stress, and works with Housing New Zealand to move John and his whānau into a larger house that is warm, safe and dry. Through health and social goal setting, with his Kaimanaaki, John sets realistic and attainable health goals and also starts attending his son's rugby games as part of his social goal setting. So that's it in a nutshell. I know I haven't touched on the clinical outcomes, kind of hopefully touched why, but I guess the question that I'd like to pose to the group is how can we add value to our approach? If you have any comments, would love to know. Yep.
Did you get the first bit? Okay. Where you have culturally appropriate or akin providers of the service for our whānau and our Pacifica populations. But here's my dilemma, okay? I run a PHO in Auckland. I've got 36,000 Maori and I've got nearly 90,000 Pacific. Mostly high needs. We're diagnosing two diabetics a day. Obviously, we can't always match up ethnic for ethnic with that sort of scale. And throughout the whole of New Zealand soon, there'll be a health coach,
Hopefully.
presumably in every GP clinic up and down the country. I guess the Patsy question is, could a Kaimanaaki be non-Maori? I'm trying to be as controversial as my esteemed colleague.
I guess it more so relates to the cultural background of the patient. We do have non-Māori Kaimanaaki who work with Māori clients, yes. I think it takes a lot of training, development and exposure to get to a level of skill where you're able to connect non-Māori with Māori. But I think ideally having someone who's culturally matched to you would be the ideal situation. But I get your point. I understand that it's not always the case. Yeah.
Well, I also want to build up on the challenge that you posed, Rauri, around that we need you. I get that. Are you suggesting, and here's a possible solution, that a co-design, led by Maori, co-design process could instill non-Maori to deliver as high efficacy service as this? I'm trying to get to solutions around scale.
Okay. Some of my best friends are not Māori.
I'm one of them. I'm not on your Facebook though.
So there's good evidence around cultural concordance. If the patient and the health practitioner have a shared culture, we know that works better. Ka pai? And so maybe one way of doing this, and I'm just testing, like you're testing, I'm going, okay, so we've demonstrated it is possible to have Kaimanaaki whānau who are not Māori, and they do okay. But, because I think I can dive into that data and say, let's rank all the Kaimanaaki whānau, and I can tell some are better than others. Make some predictions about how that works, okay? Are you okay if we pay the better ones more? Because all I'm saying is it's going to be a good thing for whānau. If you've got somebody in your whānau who can work as a Kaimanaaki whānau and they get paid better than others, that's good. I want Māori to be paid better. I'm just saying, our system, we have to change the employment statistics in this country. Currently in counties Manukau, 4% of the workforce is Māori. 15% of the population is Māori. 4% of the workforce is Māori. If we want to change the outcomes for health for Māori in counties Manukau, we've got to start employing them. We've got to start employing them now. The biggest change we can make to communities will be employment and income and housing. We've got to do that now. So yes, we can have some Kaimanaaki whānau who are not Māori. Yes, we can. We've figured that out. It's possible. But I still want more Māori working in the system. Ka pai?
Kia ora, thank you for a fantastic presentation. You mentioned at one point that the health professionals in the team weren't used to working with a team member like yourselves. I'm really interested to know what you think would help to convert those health professionals quicker. I think we need to change the way of working at scale amongst the health professionals as well.
I think, so for us, for some practices, it took a couple of months to get buy-in essentially from the clinic team. Other practices took longer, and it wasn't until, so what we did sort of on a maybe bi-monthly basis, we started spitting out reports to say, here are the clinical outcomes of the whānau that we're working with. It was when they started seeing those clinical results that said, they would say, oh, okay, cool, this thing actually works. It was small things as well, I guess. For instance, we had a Kaimanaaki who was typing visit notes into the PMS system. GPs found that really useful because they could see that, yes, the Kaimanaaki has had that touch point. So if they were going to have a consultation with the patient, they would actually bring them in and say, look, hey, do you want to sit in? I had one GP from one of our provider clinics say to me, the benefit of having a Kaimanaaki embedded into the clinic is that if we're thinking about the patient being a stage. Doctors and nurses can see everything on the stage, but they can't see behind the curtains. And what the Kaimanaaki role does is open the curtains up for them, so they see what's going on behind the scenes. But yeah, in short answer, it did take a little bit of time, and it was small change, I guess. Yeah.
I am a health professional, and so I was, to a certain extent, bagging my own. But, I've seen the real value, but I don't always see it in my colleagues. I don't always see my colleagues valuing that behind the curtains information. So the work you're doing is great. Thank you.
Thank you. I heard someone say something about recruitment. Sorry. Oh, yeah. Oh, we'll come to you afterwards. Okay.
Oh, thank you. A really interesting discussion. So in Hawke's Bay, working on developing we have what's called a whānau wellness program, which has wanting to augment, and your Kaimanaaki role looks very similar to what the Kaiwhina do with one of our practices, Total Health. Interestingly, rather than targeting patients that have a condition, they target whānau that are poorly engaged. So they offer about 21 free services, and they look at those whānau that are accessing very poorly, and the Kaiwhina invites to go and visit them. So rather than taking a disease-based approach, they take, because they figure that there's significant barriers, but then the model is quite similar. So what I've been trying to consider in terms of Paul's question is if we wanted to do this, because 26% of our enrolled patients are Māori, could we get Māori health providers to provide what I call the empowerment component, the kaupapa Māori engagement, and they partner with the practice, but we fund them separately. So we fund a Māori provider to employ the Kaimanaaki or Kaiwhina, and they partner with the practice. Interested in your views on whether that might work.
Look, I personally think it would. It's interesting that you mentioned that because our recruitment approach was basically cold calling patients on a list who are enrolled at our provider clinics. Most of them were highly unengaged with the clinic, and it was really tough to get them on board the program. We did have an attrition rate of about 20% over 2 years. I think that's a really incredible result personally because, you probably know how tough it is to get people to re-engage with their healthcare when they have no faith in the system, they don't trust it. It's really tough. Happy to share some learnings from maybe some pointers from how our Kaimanaaki approached it as well. An interesting result which will get reported on is that once we had those people engaged, the DNA stopped appearing on the PMS for our GPs. So that was something that they noticed as well. Yeah. Rawiri, anything to add?
I would disintermediate that relationship. And I've got you in a direct line with the other colleague because there's something about this interaction that the power in clinic. So we worked with clinics that were willing and we still had that problem. Essentially we had a problem of a GP going, yeah, whatever, yeah, who's that, what do they do? Shit, I'm trying to get this, come on, I've got to sort out these medications, I've got to sort out these side effects, a bloody patient doesn't come. And so not valuing the intervention until we got it to a right place. But how do you get that to pop? How do you get that to work for that clinician? And so if you think about multidisciplinary team meetings in a hospital, I remember as a trainee intern or something like that, I went to one and it was at Ward 16 at Middlemore Hospital. And the house surgeon from one team turned up and said, all right, we can start now. and the charge nurse tore strips off him. What the fuck you think you're talking about? You can fuck off. Because you think, because you're the doctor, we waited until you got here before we got started? Hell no. This is a multidisciplinary team. You want to be part of this team, get your ass here on time. You want to be part of this team, then act like you're part of this team. You're not the leader of the team just because you're a doctor. I've also seen it work with cultural support workers, badly, right? And so this is what I think you do. If you're a cultural support worker and you detect that this is a hostile environment, you retreat to what I call cultural orthodoxy. You go, this stuff that I've got so special, nobody else understands it, everything's got to start with a karakia. We're always going to need to have a waiata. We've got to do whanaungatanga. And if you want me to tell you this bit about the patient, I'm the only one who can do it, and I do it this way. And that's just, we were at the SOM. That's what we're doing. We're digging trenches, and we're occupying this space, and you're occupying your space. And we have to break through that. That's not easy. So we have to disintermediate that to get to the place where a Māori organisation is entitled to have a view and an intervention inside the clinic they don't own. You're dreaming. Tell him he's dreaming. So we've got to figure out how to break through. We've got to figure out how we take responsibility for our health professional colleagues. And we can't, so it's not easy. Nobody's pretending that shit's easy. That's hard. But we've got to front it, Clinical director, nurse lead. Okay, we've got to figure that one out. Because right now, if you just sprinkle in a little bit of a kai awhina, Kaimanaaki whānau, that ain't going to work. That's not enough. It's a good thing, but it's not sufficient. Yeah? So, good thinking. I'm interested in that. But you need her. You need somebody who can help figure out how to work with those Kaimanaaki whānau, understand the shit that's going on for them, understand what's going on for their whānau, and then we can provoke something in terms of what's happening with the clinical staff. We need to have those conversations. What's the right data we need to give to that clinic so that kind of provokes for them reflection instead of defence? Tricky, but you need her. Over.
No, short answer, no. We haven't been approached or anything, as far as I know.
That seems crazy. Just a quick comment on the Te Tumu Waiora program, which we'll be learning more about tomorrow if you're around. That is a real evolving field. The health coach and the health improvement practitioner roles are both somewhat formulated and also fairly flexible, but I'm expecting and hoping that will facilitate more engagement with NGOs, providers, more engagement across an interdisciplinary team. That's what we're hoping to see in Canterbury. So these other roles are vital as well. We need everybody being part of the team to help these people. But yeah, it's a moving feast right at this moment.
Thank you. Can I just follow up from the last one? I think it is very important because it can be very expensive. If you have this amount of engagement visits, weekly visits, and you have thousands of patients in need, it becomes very expensive. So you have to have a model that actually works far leaner and actually makes sense clinically as well, because otherwise you can say you can fund a new medication which has probably a bigger impact on your HbA1c and other outcomes. So you have to make it lean. And our little experience was we basically had one care coordinator for a much bigger population. So, and we realized it had to come from the clinician. They wanted it. They wanted to improve their DNA rates. They wanted to have better engagement with the patients that ended up in hospital all the time. So the clinicians actually asked for the role. So the role was created, co-created, not only by the patients, but by the clinicians who actually were engaging with the care worker, or with what we call a care coach. So that was one aspect. And the other aspect is the clinical impact. Because if you have a social impact, of course, you make an impact there on housing, on social welfare. But to make an impact clinically, you have to have the clinical side. So you have to support filling of scripts, you have to support medication adherence, you have to look into blister packing, you have to look on all these other clinical parameters to actually make a clinical outcome.
Yep, I agree. And we do have aspects of clinical input. The Kaimanaaki does. But I guess then a non-clinical person, so if a clinical issue arises during that Manatū visit, and that's why it's so powerful, is because you're talking to them for 1 to 2 hours, and they start mentioning, I feel a bit queasy at night time and I take my medications as my doctor tells me to. That's kind of, the Kaimanaaki are trained to see red flags essentially, and they'll take that information back to their GP and just say, hey, look, we'll just check this over. So there are clinical aspects in those visits, yes.
We're running a randomised controlled trial using navigators, but in paediatrics.
Cool.
And so one of the things that I think it's essential that our Kaimanaaki are Māori, because I was just answering the question, because I think they do multiple things at multiple levels, and we've done in-depth qualitative interviews. One of the things that they're doing is they're changing the culture on the ward.
Mm-hmm.
So our kind of Kaimanaaki are bringing in te reo me ona tikanga, they're doing waiata, they're doing karakia, te reo lessons, all of that kind of stuff. So I think they're bringing down the level of racism and the level of cultural safety at the ward level. And also they don't wear uniforms, so they're not seen as part of the system. So, for example, we will have the nurse will go in and say, kia ora whanau, even if it's a nice Māori nurse in a uniform, everything all right, are you safe to go home? And the whanau will go, yeah, fine. And then the Kaimanaaki will go in and they'll go, oh no, we don't actually have any petrol in our car. And the power's been cut off and we got no money for food and we haven't got a car seat. Yep. All of these things that the Kaimanaaki can then fix immediately and enrol them with a GP and all that kind of stuff. So I think it's really important that they are Māori. And also I think at the systems level, they need to be hooked in, what we've discovered is they need to be hooked into a manager kind of level so when they identify issues that can't be solved by themselves as Kaimanaaki or any other staff member, they needed somewhere to take it. Yep. So we discovered that whānau were going hungry because they didn't want to leave their kids. If they could leave their kids, maybe sometimes they couldn't afford the food in the hospital caf. So that was something they couldn't solve. So we have a team approach to solving that. I mean, multiple other issues. So there needs to be like a managerial, which you have as part of your research and probably part of the implementation side of it. But that's my question, is how do you put that across the Manatū program? Because it's not just, it is a program, right? And how do you link that in?
So we do have a clinic champion, like I mentioned earlier, a practice nurse or GP that is embedded into the clinic. Typically that's their go-to for the clinical stuff. Sometimes it's a go-to for accessing services like food bank, getting information on wins. But the real powerful thing I think about our Kaimanaaki is that they are embedded into their communities already. And they're well connected, and they have a network of services that they can sort of touch base with and get that input from. But yeah, it's a tricky and complex area. Yeah.
Kia ora. My name's Helen Ken, and I'm a pharmacist and a pharmacist prescriber. I work in Tokoroa, and I work in primary care, so I work in GP practices. And I'd just like to say that one of the practices I work at has got a similar role in terms of kaiwhina, and also the nurses and workers from the iwi-based services and from the South Pacific services. One of the most powerful things that I've found as a pharmacist, obviously my role is around medications among other things, is when those kāwhina bring people to see me and say, you can trust Helen. Because that gives me the opening where people will go, okay, this lady's okay, I don't have to be concerned about what she's going to do. So I'd just like to attest to that role as well.
Brilliant, thank you.
It's just a very quick question, but what training do you give them? Because you mentioned that they do like DSME with a family, but that's quite a specific thing. So, yeah, what kind of training do you set them up with?
Yep, so we sent them on quite a few different DSME courses. We had a workshop specifically tailored to our group, I think. You can call it sort of a culturally tailored DSME approach. They initially completed a 2-day full-on workshop to learn the sort of, I guess, the core values of the Manatū model, but it was a training that was sort of ongoing. They did a lot, health literacy. They did one with Health Foundation, Pacifica Healthy Eating. That was brilliant. They raved about that, but yeah, it took a lot to sort of, for them to build up that confidence in themselves to be able to deliver that information. But yeah, does that answer your question? So a lot in essence, yeah. Yeah.
Kia ora. I was wondering if in the co-design process that included the power sharing around recruitment of Kaimanaaki. So by identifying, if your community gets to identify what they really want in that role and what sort of people they'd like in that role, they'll often source those people for you too. They'll identify who could come along and be recruited. So it's not sort of, you tell us what you'd like, we'll go off and recruit things.
Yeah. And that's a brilliant point. That's not something that we actively did with regard to recruitment of the Kaimanaaki. Our approach was very much, let's work with the GP clinics, and the GP clinics would say, well, we know our patient population, we know what they want. But that is a very fair point. That's something that I think is really important to look into. Yeah.
So my name's Rachel and I work in planning and funding in Canterbury, but prior to that I worked in general practice for about 9 years as a practice nurse. And then I went to work as a community nurse. And so when I was in general practice, I worked in a low decile practice, and I thought I understood these equity problems, because of the people who came in our door and we saw every day. It wasn't until I went to the community and worked as a community nurse in a low decile school in a community centre that I realised I didn't know anything. I thought I did. And what I learnt from that role is that as health professions working in general practice, we think we know. We actually don't. It's not until you've been into these roles that you realise the barriers that people face. And without time, which we don't have in general practice, without these roles, we're not going to make a difference.
Yep, tautoko that. I should add, one of the feedback from our Kaimanaaki is, because they go out into people's homes and they work with them in their homes, and it's shocking, and that's why we, in our peer support reflection sessions, we had to have a health psychologist there, because some of the stuff is so shocking. But yeah, one of the Kaimanaaki actually said to me, it's important to go to their homes because there's nowhere to hide. They can't hide anything there. So yeah, I completely agree with you. Yeah.
Just want to say Thank you, and thank you, Rawiri. These discussions have been just so valuable and
Choice.
long overdue, I may say, in primary health care. But if you all come to the Whaimua program, which will be on tomorrow, you'll see a couple of our navigators or paiarehi for whānau ora will enlighten you on the 2-year study they did with COPD patients.
Brilliant.
They do a brilliant job.
Kia ora. Okay, I think we're out of time, but thank you, everybody.
Join me in thanking.
Hope that was helpful. Yeah. Oh, sorry. Yep.
The mea tōtahi māku Taria mihi atu gaua. O the mea he pūkai ka hano i te tūki te kōre. A ki ngā kaupapa pāna ki te Māori. I would like to commend you for such a young person to be able to speak on things that are very touching, not only in the field of assistance and medical assistance, but tikanga Māori, because that's even difficult for Māori people. So for a person so young as you are, to tackle it is pretty hard. But one of the things I would like to ask Taria, your pool or repository of knowledge on Māori things, where does it come from?
My dad.
Thank you. That's it.
Short answer.
That's really important, because if you're dealing with Māori things, then it must be your close relation that can be what irrefutable, I suppose, is the word.
I ring him up probably 3 times a week. Will they hear pātai like?
Yeah. The thing about it is, I pondered on the use of the word manatu. And I listened to how you explain manatu, and it's different to how I see it.
Yeah.
So that's why I say, where is it? Manaki is an interesting term, because it's a mana to lift, and that's what the thing. But the manatu is quite different, because the nā kupu, the tu, is stop. So
it's different interpretations, yes. Yeah.
So that's the thing. That's why I asked. Nō reira, kia ora.
Kia ora. Thank you, matua.
Please join me in thanking Taria.
Thank you.
I'll hand it over to you, Sue. Thank you, Taria. That was great. I'll let the others know.
Hoi anō, māku te kōrero whakahoki, mo tēnei kōrero mo te manatū, kei pōneke tātou kia tūpato tērā mo te kōrero te manatū hauora, te manatū ahara, he whakatika tau. Ka whai tēnei kōrero mo te manatū i tērā āhuatanga o te tū tangata. Koia tērā, ko te mana o te tangata kia tū aia me ōna āhuatanga katoa, te māwiwi te aharani. So that was a good answer. It was a very good explanation. But I've got a question for you guys. So I'm saying I've asked the Ministry of Health, Health Promotions Agency, DHBs and PHOs to consider now what we do for COVID-19, to call a hui for our senior Māori experts in tikanga and our senior Māori experts in public health, because we need to have a conversation about COVID-19. We know it's coming, right? We all know it's coming. The advice is get ready because it's tomorrow. It ain't tomorrow, but it's coming soon, right? So get ready. What does that mean for us? Because the mortality from this is less than SARS and MERS, true. But the mortality is strongly associated with the over 70s age group. If we were looking at a 10% mortality for the over 70s, that would be devastating for Māori community. So what is it that we do differently? So yesterday I was out at the airport marae in Auckland. What is it that we will do differently in Pōwhiri? What is it that we will do differently for tangihanga? How will we fulfil the obligations we have around manaakitanga or whakatau or tangihanga or whatever it is, but we do it in a way that's going to protect our old people. Ane, ko taku wero ka whakahuati ki a kōrua. Kia ora rā. And everybody else can come back in now.
Okay, so it's time to wrap up for the day. I just want to really awhi everybody who, there's been a tremendous amount of energy in the room. There's been a lot of knowledge, a lot of insights, a lot of sharing. I know that I feel that it's a really rich download of just information, and there are many things that I need to go away and just reflect on. I'm sure other people will feel the same, and I encourage you just to reflect and process over this evening. Tomorrow morning we will have a wee time where we can really focus on the themes. I think it's a bit too much to do that. We've had a lot of interaction and good kōrero with back and forth, and so now I think it's time to go home, rest and recuperate, reflect and come back. But tomorrow would really have that opportunity to say what are the key highlights and what are the key themes that are emerging. And then at the end of the day tomorrow, there is going to be an opportunity for gathering together what are the most pragmatic, and actually rising to John Whanga's challenge for us to each individually think about what difference can we make, because this is a powerful group. I think that this is my third or fourth long-term conditions conference, and I've heard people saying it today, that the conversation really moves on. And so even from last year, this equity conversation has really moved on to a whole different level, a whole different place. And it's because of people, just coming and sharing their thoughts and then going out. It's bigger than just this group, obviously, but I think this group's influential. So thank you. And go and have a very good night. And there's the Red Gates. Don't forget an opportunity to gather at the Red Gate Bar. Okay.